Everybody, welcome this evening to our webinar, Resuming Breast Cancer Screenings and COVID-19 Updates with Dr. Laura Esserman. We are so thrilled to have her this evening and really appreciate everybody on this call. I'm Jenna Fields. I'm the California Regional Director for Sharsheret. I'm going to speak for just a few minutes and then turn the floor over to Dr. Esserman. So I just want to share a little bit about Sharsheret if we are completely new to you. We are the National Jewish Breast and Ovarian Cancer Support Organization. We provide free psychosocial support for people of all backgrounds across the country, providing support and education no matter where you are in your breast and ovarian cancer journey, as well as those who have increased genetic risk. We know this is a really difficult time right now. We have a team of social workers who are available to talk with you about what you're dealing with, so please don't hesitate to reach out to us. We also provide community health education. We've been doing webinars every single week since the COVID-19 pandemic started. I want to plug two of our upcoming webinars. One is this Friday. We're doing a Shalom Shabbat, which is going to be during the daytime and an opportunity for anyone to join us to reflect on the week, the month, the year that has been, and to feel empowered and have opportunity to reflect at the end of the week. And then we are also doing a program I am so excited about, which is on August 16th, Ruth Bader Ginsburg's personal trainer is going to be our guest speaker, and he's going to be talking about the RBG workout, how she stays strong, and so can you, in partnership with Two Unstoppable. So we'll be sending out information about that training. Right now, you can actually register for both of those webinars. The link is in the chat box. A quick medical disclaimer, Sharsheret is a national not-for-profit cancer organization and does not provide any medical advice or perform any medical procedures. The information provided tonight is not a substitute for medical advice or treatment for specific medical conditions. We always want you to seek the advice of your physician or qualified health provider. I want to thank our sponsors, the Sigmund and Edith Blumenthal Foundation. I see there's a survey that popped up on the screen, so we're also going to ask you to take a quick survey as I'm finishing here, which is our Zoom etiquette. So everyone on this call has been muted. Please keep yourself on mute throughout the remainder of the program. If you have questions, we have a great active chat box. Please type in your questions. And when we get to the end of Dr. Esserman's presentation, we'll go back to those questions and get to as many as we can. If you would like to remain anonymous, now is the time to turn off your video at the bottom left-hand corner of your screen by clicking Stop Video. You can also rename yourself by clicking on the three dots on the top right side of the screen so your name is anonymous. This program is going to be recorded, so if you miss anything, we will be sending out the recording within the next week, but your video will not be on the recording, only the video of the people speaking. And now it's my pleasure to introduce Dr. Esserman. She is an MD, MBA, and an internationally recognized breast surgeon, breast oncology specialist, and a visionary in personalized medicine who is revolutionizing breast cancer screening and treatment throughout our nation today. As a professor of surgery and radiology at the University of California, San Francisco, and the director of UCSF Carol Franc Buck Breast Care Center, Dr. Esserman's breast cancer work spans a spectrum from basic science to public policy issues and the impact of both on the delivery of clinical care. She has been involved with many studies, but I want to highlight her creation of the University of California-wide Athena Breast Health Network, a learning system designed to integrate clinical care and research as it follows 150 women from screening through treatment and outcomes. And as part of that study, or part of the network, she's spearheading the development of the Wisdom Study to learn how to improve breast cancer screening by testing and comparing the safety and efficacy of a personalized screening strategy. She's published more than 300 articles in peer-reviewed journals and is regularly consulted by the prestigious scientific business and consumer media. I could read so much more from her bio, but I won't because I want to turn it over to our esteemed presenter, Dr. Esserman. Thank you so much for sharing your time this evening.
You're welcome, and thanks so much for inviting me to talk. And I'm happy to talk to you guys tonight. It's I think a really challenging time for everybody. I think everyone is sick of sheltering in place or social distancing and wearing masks, and it's feeling like, when is this all going to end, and are we ever going to get back to normal, or what is the new normal? And so I think that for the time being, I think we have to really think about how do we deliver care in the time of COVID. And so first, just in case any of you wanted a little more detail about what COVID really is. So the virus is SARS-CoV-2. The disease it causes is COVID-19. 19 actually stands for the year that it was discovered. That was in November 2019. So that's why it's COVID-19. So coronavirus is an RNA virus, and viruses work by, they by themselves are kind of innocuous things. They're basically a piece of RNA surrounded by a protein envelope. By themselves, they do nothing, but what they do is they kind of find a way into normal cells and harness the machinery of those cells to basically replicate themselves. And they basically turn your cells into a little virus factory. This virus originated in bats, went to pangolins, and then jumped to human. So it's got pieces of bat, pangolin, and now human. And the disease itself actually ranges in severity from mild to lethal. And we're going to focus on this theme because this comes up over and over again. Almost every disease we know of has this range where some people get very ill, or just like a cancer, it can be incredibly aggressive, or it can be really innocuous. And that's true for this virus too. Now, how does this particular virus get in? It gets in through something called ACE inhibitors. And these ACE, you may have heard about it, through the ACE receptor. ACE inhibitors are very common blood pressure medications. These are things that are regulated. The ACE inhibitors are in many cells. One of the reasons why we think that kids are not as infectious as adults is because they have fewer ACE receptors. Another interesting thing is this little thing, TMPRSS2. This is actually regulated by male hormones and testosterone, and this is actually a target in prostate cancer for hormonal suppression, androgen suppression, is through TMPRSS2, and this sort of combines to when the virus binds to the ACE inhibitor, it's then enabled to sneak in that way. So that's the virus, that's what it looks like. And what's a pangolin? Well, a pangolin is like a scaly, just in case you wanted to know what a pangolin looked like. It's a scaly anteater like animal. And this is probably the reason why this happened, is that pangolins are sold in these Chinese markets. And that's actually how the virus got from the bats to the pangolins to people in this very crowded market. So this will not be the last pandemic. And you'll see when we get back to it, we really have to put things in place so that we know how to respond. So every time something like this happens, the economy doesn't stop, your world doesn't stop, and we have to be able to think about it. So it's interesting when you look at the incidence of deaths of coronavirus worldwide. When I first made this slide, there were 8 million cases and 435 deaths. A month later, there were 14,000 cases and almost 600,000 deaths. And just yesterday, we are up again another 4.5 million, up to 18 million, with almost 700,000 deaths. So this virus worldwide is just going at this incredibly steady pace. And unfortunately, we in the United States are leading the charge. So what have we learned? And what happened when the virus first came in place? So when it first became clear that this was going to be a pandemic, what did we do? All these hospitals shut down. And why did that happen? It happened because we just weren't prepared. We didn't have mechanisms in place to screen everybody. We didn't have enough personal protective equipment. We didn't know what the pace was going to be. We didn't know if our facilities were going to be overwhelmed. And some of them were, like in New York, I think Columbia Presbyterian Hospital at one point had 1,500 people in their hospital system, with 500 people in their ICUs and people in, not just in operating rooms, but in cafeterias, beds were set up. And so when that happens, simple things happen. Oxygen tanks run out because they're not in a standard way of doing things. This is what all hospitals are trying to avoid, is being overwhelmed so they can't take care of people. And we needed time also to figure out, how do we organize surgical procedures? When you put someone under anesthesia, and you're intubating someone, all of their air gets, their aerosolization of particles can infect everybody in the room. So again, we had to have testing in place, make sure that people didn't have the virus, so we wouldn't put them at risk when they were put to sleep, nor the anesthesiologist, nor the teams in the room. We needed time to figure out exactly how was this being spread. Is this being spread through coughing? Is it being spread through surfaces? And by and large, this virus is spread in a respiratory fashion. And the most important thing you can do is wear a mask. And if everybody were to wear a mask, if 95% of people in this country wore a mask, it would be the equivalent of a shutdown, and we would be able to get this in control. And especially with the prevalence today, we must do everything we can to fight against the politicization of mask wearing. It has nothing to do with Democrat, Republican, smart, stupid, red, blue, black, whatever. It's all about being smart and wearing a mask. And I think it's important that we don't ever want to be in a position where hospitals are overwhelmed with COVID cases. And where that's true, that's not a great place to get your care. So how did people adjust? Well, people adjusted with things that we actually have known now for many years. And in fact, one of the ways in which we're advancing care for women with very aggressive breast cancer is to start with surgery. We start with systemic treatment like chemotherapy or biologic treatments first, because it turns out the order of treatment doesn't change your survival, but it can really improve your options. If you know whether someone's responding, you know that they're getting the right medicine. And if you have a great response, your surgical options may be very much better. You could do quite a bit less. So this becomes super important. And guidance from the oncology societies recommended that at the beginning, when we had shut down our ORs, to think about starting with systemic therapy. Now, and also to remind people that treatment is not an emergency. Cancer is an emergency because you know about it. It's not usually because it showed up that morning. It's usually been there for months or longer, and that there's plenty of time to sort out what your options are. Getting special tests to really understand, getting the treatment right is much more important than doing it fast. We know that. It just is something that people don't understand very well. Now, many major medical centers and the leaders in care already follow these practices. And in fact, the focus of practice-changing trials, like I-SPY and others, is really all about trying to figure out how to get that treatment right so we can accelerate the pace of learning and increase the chance that people will survive even a bad cancer. Now, one of the big challenges for people is care support at the medical center. And for many, many months, no one was allowed in with people. And we went back to a time when people were given information alone and told about things by themselves. And that really was a struggle. And people getting care often were isolated and couldn't be around someone. Someone getting chemotherapy was told not to go out and to be completely isolated and couldn't be really around someone who's going in and out of the home. And this is just when you need it most and just when you need your friends around you. Having that void is a big problem. So we can't just say, oh, well, that's COVID and we have to do that. We have to make adjustments to make it better for people. So I think a lot of active cancer patients and survivors face this heightened challenge because they felt much more vulnerable. Now, it turns out that when you're getting chemotherapy, you are at higher risk. And if you happen to get COVID, your outcomes are worse. So you shouldn't be the one going to the store. You shouldn't be going out doing a bunch of other things, but you can get care support through Zoom, through calls. Doesn't mean that it's not important that you should be doing it. But I think this kind of made people at all stages, even when they're well into their survivorship period, it intensified their fear of recurrence. And people then were afraid to go to the store. They weren't getting, safe access to basic nutrition and healthy things. And I think that, plus all the demands on households, taking care of kids, and all the things that have made it so challenging in this pandemic has made it really very challenging. And we know that social isolation increases anxiety and depression. And we've seen this. Our psychosocial services at our institution and almost all institutions have been overwhelmed by calls and appointment requests. So how do we try and adapt? The silver lining is that every crisis brings opportunity, and finding better ways to provide support may actually change the way we do support even after COVID. Having the support of loved ones is just simply an essential part of care. No patient should ever have to face any treatment decision alone. Video visits are now, were vanishingly rare prior to COVID. Now all of a sudden they're paid for by every insurer, by Medicare, by Medicaid. It's like now 80% of all visits are being done that way. And I don't think we're ever going back to the old way of doing things. If you have to come in, you come in. If you don't have to come in, you can do a video visit. This is good for patients and it's good for physicians. And the good thing is that family can join, friends can join, they can be part of that video visit, so you don't have to be alone. Caregivers and note takers can join in-person appointments by Zoom. There's no reason not to do that. And if you want someone to join, insist on it. Don't feel like you have to then start and forget to bring someone in. Insist that the people you want to be present should be present. We have a program where we use students, interns. We have a post-baccalaureate internship program. People spend 1 or 2 years in our program, and they have been doing for decades, calling patients ahead of time, finding out what their concerns and questions are, providing this support to the patients, to the physician. So, and then showing up at the sessions and recording the consultation, and they are the note takers. And in fact, you can do that in COVID just as well. And now more people are sort of taking up those services and spreading something that we think is really, really important. And they can be the ones to help get families to participate in the Zoom calls. Another really important thing that's happened is that we transitioned our survivorship and wellness programs into a telehealth-based program. And this was actually great because it expanded the reach of the program and it tripled the number of people who could participate. And if you think about it, people who work, they have small children, they live far, access is actually a really huge problem. So this may actually really increase the reach of our psychosocial group support programs. And, again, magically now insurance companies are covering that. So these are the silver linings and really important. Okay, so what about screening and what about care? If I have a cancer, should I get care? If I need to get screened, should I go in? So initially screening was put on hold. So really from March to about middle of March, middle of June, like everyone shut down. And I think until we knew what was going on, people just weren't going in. So then the real question is it safe to get care? Really, what should I do? So I'm going to take you through a series of examples to show you what the relative trade-offs are. So you want to compare what's my chance of getting COVID versus finding an early cancer with screening where it might really benefit me to have that cancer taken care of early. So if you take 100,000 women and you say, what is their chance of getting COVID if they go in to get a mammogram? That's about 1 to 3 versus 100 to 200 people who might have a cancer that would be found. And if you're older, where the cancer rates are higher, now we're talking about something that's 500 times more benefit. And the chance of finding a cancer, of course, depends on your age. Well, what about your chance of dying if you skip cancer treatment compared to your chance of dying of COVID? So if you take 1 million women and you go in for 10 treatments that are important, your chance of dying of COVID would be about 3 versus somewhere in the 100 to 500,000 fold. So we're talking about 100,000 fold difference. And, you know, again, the risks and benefits depend on your age, your overall health, everything else. Even when you're older, where you're at much bigger risk of dying of COVID, if you got it, you're still looking at something that's 1,000 to 100,000 times more important to get treatment for in terms of saving your life. So if you have a cancer, don't skip treatment. If you have a cancer, find out what your treatment alternatives are, because you might be surprised that some of them are much easier. Maybe you only need hormone therapy, or maybe you could do hormone therapy for 6 months before you have surgery. There's lots of options and there's lots of ways to mix and match treatment. That's one of the things that we've learned. Now, is this true for everyone? Well, what does this depend on? It depends on the prevalence of SARS-CoV-2 in the population. Now, this is estimated for the prevalence in the Bay Area, which is 1%. I was just in Miami, where the prevalence is 20%, so it's quite a bit different there, and the situation is different. It depends on your access to transportation to a medical facility. In that first case example I gave you, was if you drove and you didn't have to take public transportation. And it also depends on whether the healthcare facilities in your area are taking safety precautions. Are they screening everybody? Do they have, are they making everyone wear masks? Is everyone sort of, you know, gelling up, and is everyone being careful, and are you minimizing the risk of exposure in waiting rooms, et cetera? So if you add the challenge of access and public transportation, and we'll just take the example of screening, you know, it's still, you know, the chance is about 10 to 50 times higher that you would find a cancer, and where the benefit would outweigh the risks of getting COVID. Well, what if the prevalence is 10% or even 20%? Again, if it's just that, it's 10 to 20, it's still reasonably easy to go in as long as you can get there safely. But if the prevalence was 10% and you had to go into public transportation, now it's maybe 10-fold higher, or, you know, 20-fold higher. It's starting to be not quite as big a benefit. And if you have contact with many, the prevalence is 10% and no one's wearing a mask, okay, your chance of getting COVID is higher. So it does depend, right? But if you're in an area where the prevalence isn't high, you can drive to a facility, there is no reason for you not to be able to go in and do things safely. If you have to take public transportation, if no one's wearing a mask, and especially if you're not going to wear a mask, don't go out. Because, you know, the risk of this virus is that it's spread by people who are not ill. That's the problem. So if anybody wants the math, here it all is. I won't go into it and bore you, but I wanted to let you know really that we did go through the math, and it's all been checked with the epidemiologists. So what's the bottom line? If you have safe access to care, if you wear a mask, if you go to a facility that follows the public health precautions and everyone wears a mask, it's safe to proceed with care. And you are worse off by not getting your cancer treated. No question about it. So then people would say, well, how do I know I should even go in and get screened? Does it really matter? There's all of this confusion about screening. You know, does everyone need the same screening treatment? And what's the right frequency to screen? This kind of general confusion really is highlighted by the crisis with COVID, and makes it even more important to know, when should I screen? You know, maybe my friend Sandy is screening, you know, every 6 months. Do I need to screen every 6 months? Or what about my physician told me to come in every 2 years, and my radiologist told me to come in every year? So how do I know what to do? Well, this is actually a big problem, and it didn't start with COVID. The experts don't agree, and there are at least 7 different guidelines, and some say start at 40, some say start at 45, some people say start at 50. You know, what's a person to do? How do we figure all this out? So let's take a step back. So why do we screen in the first place? We screen because breast cancer can be deadly. There are more than 40,000 women a year who die from breast cancer in the US alone. And by the way, they're dying despite screening every year. So we've made some progress. Some of it's from treatment, some of it's from screening, but clearly what we're doing still isn't good enough. So how do we apply what we've learned about breast cancer treatments to screening? We don't treat everybody the same when they have breast cancer. So maybe one size doesn't fit all for screening either. So it turns out there have been a lot of advances in science and technology. We know a lot more about prevention. We've learned a lot more about risk assessment. About 24 years ago, the BRCA gene was sequenced. 23 years ago, the BRCA2 gene was sequenced. There are now 9 or 10 genes that are associated with, that you can inherit and have a much higher risk of getting breast cancer. Now, these are pretty rare. Only 1 to 2% of the population maybe has these. But then there's a bunch of genes that you can inherit that the small variations and small differences actually make a difference in how risky it is for you to get breast cancer. And it turns out the laws, fortunately, that most of these have stayed intact, protect you. If you have genetic information that tells you at risk, you can't lose your insurance. That's what HIPAA actually really is. It's the Health Portability Act actually protects you. And then there's the GINA law that also says that you can't be discriminated against on the basis of genetic information. And the Supreme Court actually said you can't own the genome, so Myriad no longer has the patent on genetic testing, which then opened the door to next-gen sequencing and much cheaper, faster, better ways of doing these tests. And gosh, now we can do the genetic sequencing for the price of a mammogram. So that turns out to be a huge, and actually cheaper than a mammogram. So maybe you should get screened based on your risk. Family history, genetics, breast density, age, your race, other types of breast disease, lifestyle and exposure. So what we designed was a study called WISDOM, Women Informed to Screen Depending on Measures of Risk. And we said, well, we think that it's high time that we looked at trying to personalize screening. Some people need more, some people need less. And even within the guidelines, we could start down the path of trying to do more for some, less for others. And as we learn, we can further improve. If you had a super low risk of getting breast cancer, you might just get the harms of screening. What are those? Getting called back? Any of you who've been called back for a mammogram, it's a terrifying experience. And who wants that if you don't need it, right? But if you are at high risk, it's probably important for you to screen even more frequently. And more important than screening is prevention. If you actually have high risk, the first thing to do is reduce your risk. And screening doesn't do that. It reduces the risk that you'll die of the cancer, but it doesn't reduce your risk of ever getting that cancer. So we wanted to put a comprehensive program in place and test it against the annual screening starting at 40. Any woman between 40 and 70 can do this anywhere around the country. You could go to wisdomstudy.org and sign up even while you're listening to me. It's that easy. But we're asking people to commit and be part of this study to help us learn. All changes, all advances in science come from people participating in science and believing that they can make a difference. And if you've had cancer, I'm sure you must know 10 people who haven't had cancer who could participate. We want to randomly assign people to personalized screening versus annual screening because that's one of the ways we learn. But it turns out that we want everybody to participate, so that if you have a strong preference and you want the personalized arm or you want the annual screening because you're not going to do anything other than annual screening, then choose that arm. And there's lots we can learn and you can participate. And we want to ask, right, is it just as safe to do it this way? Does it reduce false alarms to do a personalized approach? Do most women actually prefer to have a personalized approach? And by knowing your risk, are you more motivated to take up preventive interventions? And at the end of the day, do we do better? Is it better value for you and better value for the country? And we know that risks vary based on race and ethnicity. African-American women used to be less likely to get cancer. Now they're catching up, but their mortality rate is higher because they're more at risk for certain kinds of cancers like triple negative cancers, but not everybody. So it's really important to us that people of all backgrounds participate in the study, because we want our policies to reflect everyone in the country. And the great news is you can do this while you're sheltering in place. This is something you can do online. So it is actually time to improve the way in which we screen, and it's something that everyone can help us with. And if you do join us, we hope you'll stay with us. You just have to make sure that you stay in contact and you say, wow, this is really important to me. This is a way I can contribute and learn for myself, my sisters, my mother, my kids, and all my friends. We have almost 30,000 women on board. We do want to get another 50,000 women if we can. So spread the word. So it's very remote. You can do it remotely. You can, and even if you're in the personalized arm, the genetic testing kits come right to your door. You do have to go in and get a mammogram at some point. So again, what's the silver learning? Some things actually are better. We have streamlined processes for telemedicine and care support. And it's clear that we need to determine who needs what. So really what that says is that research is essential. And just like we said around the program for screening, part of the reason why I'm pushing a personalized medicine approach is there are people who have really indolent cancers. They're very low risk. So why, especially in a pandemic, do you need, if you were 70 and had an ultra low risk cancer, you don't need, you barely even need hormone therapy. You don't need to go in for radiation. There's a lot of things you don't need to go. So if you have less risk, you want to do less. You want to de-escalate. If you have a higher risk, you want to do more. If you have a great response to therapy, you don't have to keep getting more and more therapy. If you don't have a good response, then you have to do more. So this is the way in which personalized medicine is going to be changing, not just breast cancer actually, but all of cancer. And this is actually part of a big trial that we run called the I-SPY trial. And this is actually a trial. We did not shut this trial down during the pandemic. A lot of people shut down all research, but I actually believe I'm the national leader of this trial. And I felt like the options that we offered as part of this trial actually gave people better outcomes than the standard treatments that we have. And over the course of this study, we've had 2 people who've gotten COVID, 1 during treatment, 1 in survivorship, and everyone has done fine. And I think the focus of this trial really is to say, who are the people who are most at risk to die early? And those are people with stage 2 and 3 breast cancer, who, those tumors are 2 or 3 centimeters at least, or node positive. These are the people who are likely to get recurrence early. And what we really tried to do is move the treatment to an earlier stage. So all these new medicines that are being developed, we want to give them not in the metastatic setting, but up front so that we can prevent people from getting metastatic disease. Again, it's that notion of changing the order of therapy. I'm a surgeon. When someone comes in with a cancer that's likely to be risky because it can spread somewhere in the body, surgery doesn't fix that. Systemic treatment fixes that. So you want to use your craft wisely. So, and it also gives us this chance to learn early in the course of care. And by creating one trial where we constantly put in more and more and more agents and we keep testing, we've tested now, we're on our 24th agent that's come in. We have 20 sites across the country that are learning together, helping change the way in which we approve medicines and move things forward. This is the whole number of cases that have come through. And what we're trying to do, this is someone who had a big cancer. You can see this big cancer right here. And this happened to be someone who was on one of the immuno-oncology agents. And not everybody, not everyone, not every type of cancer responds to this, but we figured out which tumors responded and it went away. And why is that important? It's important because, and this is the difference in, our hormone negative cancers were the ones that responded the best. And why did that matter? Because people who respond well have a 92% chance of survival, whereas people who don't respond well are down around 65%. So we want to find out sooner. We want to drive these changes. This is the kind of thing that we're trying to do. So we did not stop this trial because we've got the new agents that we think are going to matter. But we did make a lot of changes to the trial. Patients were doing well and stable. Instead of making them come in for an in-person visit, we can do video visits on the weeks when the treatments weren't being given. We reduced some of the interventions. We allowed labs to be drawn locally. There's lots of ways in which we can make it easier for people to participate in research, because truly clinical trials are today's therapies. They're tomorrow's therapies that you can get access to today. That's the purpose. And a lot of people think, oh, why would I be part of a trial? Well, that is the vanguard. You want to be part of, better, I think, better care. And you often have you get a study coordinator who also gives you special attention, which is good. So now why do I bring this up? Because with COVID, there's an even greater urgency. At one point in the pandemic, more people were dying of COVID than heart disease or cancer altogether. And what is the real problem with COVID-19? The problem is not that everyone is getting sick and dying. In fact, 90% of people who get COVID don't get that sick. Half the people who get it, it's a mild disease. But the problem is, for about 10% of people, they get very sick, and 1 or 2% will die. And we don't really understand why that is. So like cancer, everyone doesn't have a lethal disease, and they don't have a lethal case. So this is important for everyone to think about how we think about disease and how we think about treatments and how we think about personalizing treatments. So solving this problem is crucial, not just for this virus, but for other future viruses. So we have to prioritize finding these high impact treatments for people who are critically ill and getting into the ICU. So saving the person who's got a mild case, just like someone who's got a very mild case of breast cancer, and over-treating them doesn't help them, right? Over-treating someone with a mild case of COVID isn't going to save the person in the ICU, right? And just as important as finding a vaccine is finding the treatments for the people who are really sick. The economy is not going to recover until we solve this problem. And this is our problem. We have truly well over 100,000 deaths that we should never have had. But here we are, with, 5 million cases and 154,000 deaths, still high, coming down a little bit. We have to solve this problem. So what was the fastest way forward for those who are critically ill? We actually took the I-SPY network and all the principles we put in place for that I-SPY trial, which is the first and longest running platform adaptive trial, where you're testing multiple agents with one control. It's a much more efficient approach. And we've taken that same platform and turned it into a learning engine for COVID. We partnered with our colleagues in the ICU. And we're looking again for those same exciting new agents that might make a difference. There's a lot of repurposed drugs that we can use. Finding agents with a big impact to speed time to recovery and drop mortality, and finding fast what does have an impact and what doesn't. And harnessing that same infrastructure and building a learning engine. And that's how we built the I-SPY COVID trial. So we have 4 drugs at a time. And we just opened up, and that's really exciting. And so what are we looking at? We're looking at things that change the immune system, because some people get sick because their immune system overreacts. And so it's just the opposite of what we need in cancer. So we have to drop that down. Some of it's about repairing the cells that are attacked. That is, drugs that are affecting how you clot, drugs that are affecting how you form Polenzyme, looking at drugs for cystic fibrosis that allow people to breathe better, and then combining that with antivirals. So the exciting thing is this trial just opened. Our first patient was put on last Thursday. We're very exciting, and there's 8 more sites opening up this week. So we're very excited about that. And so I'm very optimistic, because I'm optimistic by nature, because I believe that research is the key to changing the world. And I think that there is, one of the things that's amazing is the unprecedented, I would just say that the COVID R&D Alliance, I have been working in drug development for over a decade, and I have never seen the kind of collaboration people have. People are finding everything they think could possibly work. People are working together. thinking about how to manufacture things, people should take hope. I am sure that within that pile of 10, I mean, I can barely keep up with the things that are promising to be able to test. What we have to do is have efficient platforms to test them. And if everybody were on a trial like this, we would find it by the end of something at the end of the year. So be hopeful. So I would say, before opening up for questions, I would say the COVID for now is pretty well established in the population. So for many months to come, we're going to have to live with it. So you're going to have to make some adjustments. Everyone has to wear a mask. So that's okay. That's not going to kill anyone to wear a mask. Get everyone you know, every kid, every adult, everyone should just be wearing a mask. It's safe to get care if the prevalence in your area is fairly low. You wear a mask and your healthcare facility is following public health precautions. And if you have a cancer, even if it's, the prevalence in your area is not that low, it's still by far safer for you to get treatment. But you can be creative and work with your physicians about better options for care and rearranging the order of therapy because that's safe. So we have to find ways to integrate social support. That really matters. And maybe we can do better than we've done in the past. And I'd say that the critical research questions need to be asked. The key to better options for screening, care, survivorship, and COVID are all going to come from research. So with that, I'll take questions.
Thank you so much, Dr. Esserman. There was a lot in your presentation to digest, and I really appreciate the fresh perspective you brought to a lot of these issues. I'm going to take questions in the chat as well as questions that have come in advance. I'm going to start with questions about COVID. Question about risk for COVID-19 and someone's immunity. Someone said that she's out of chemotherapy for 5 years, but was told that her immune system is still impaired and she's at higher risk for COVID because of it. Is that something that you are advising patients, or what are your thoughts on that?
I think that depends. I mean, most people who are out of chemotherapy are not at persistent risk. There are some people whose white count is affected and just has never recovered. That's actually fairly unusual, but that may be true. You should kind of make sure that that really is true and that your immune system isn't working. Once your counts have recovered, you really aren't at increased risk. Again, if everyone takes precautions, it's actually fairly safe. Remember, if everyone wore a mask, if we just got that message out, everyone would be so much safer.
And would you recommend going to an outside imaging facility versus one attached to a hospital? Does that affect risk at all?
I think, again, it depends. Some of the hospitals, I think, are really well organized with the way in which they're using personal protection. I mean, everyone's using personal protective equipment and screening everyone at the door. If the facility that you go to is expert, again, it's important to go to a facility where there's a lot of expertise in reading mammograms. If not, your chance of getting a false positive or missing a cancer is much higher. So it's really important to go to a place where there's a lot of expertise and people are used to doing that. And I think it's important to go to a place where you're sure that they're taking precautions and they have the resources and to keep everything clean and safe for you.
Great. Great. A question about MRIs versus mammograms. When is an MRI recommended versus a mammogram?
Okay, MRIs are way overused. I use MRIs in the part of iSpy, and I worked with the person who actually developed all the sequences for MRI, so I know lots about them, and I think they're great. However, they're often misused and used too often. If you have a new cancer and it's found on exam and it's not seen on mammogram, an MRI is important to see what's there. If you have very dense breast tissue, an MRI can be useful. For screening, only people at much higher risk should be given MRIs because their false positive rate is extremely high, 30 to 40%. And the only way you can, find things sometimes is with an MRI biopsy, and people overcall things on MRIs all the time. So it's good to use if you need it. If you're in one of those, like we very less than 5% of people are really recommended in wisdom to use MRIs, but it's the people truly at high risk. And if you're a mutation carrier or you really have super high risk, yes, it's important. You should get screened every year with an MRI, every year with a mammogram, and alternating in between. And by the way, if you have very dense breasts and if you're at high risk, it's not ultrasound you should use, it's an MRI. But if you're not at high risk, and especially if you've got relatively fatty breast tissue, you don't want to get an MRI. It's not helpful.
And what are your thoughts on thermography as a way to avoid?
Great idea. It doesn't work.
Okay.
Don't waste your money, and it's not covered for a reason. And I'm sure you could think about the money that you would spend on a thermogram and go find something really fun and good to buy with that and go do that.
Question about BRCA testing. I have BRCA2 mutation, does my daughter and sister. My granddaughter is 11. At what age do you recommend testing?
So we don't usually recommend people get tested until they're like at least over 18. And, you know, you have to think about it. You know, the hallmark of a BRCA cancer is that you get it at an early age. But you can look in families and see sometimes families get it at 40s and some are getting it very young. So if the history is young, then you have to think about it early on. A lot of people, when they get to be 21 or so, should they get tested or not? I think that it's probably better to get tested because remember, there's a 50-50 chance that you'll be negative. And I was arguing with that with one of my patients and she said, well, no point in my getting tested. And I said, you know, she was like having all these false positive exams. I said, get tested before we do another biopsy. And she turned out to be negative. So I think most people think they've got it till they get tested. So you might as well get the test and figure it out if it's in your family. And we'll see, maybe wisdom will show us that, you know, sometime around the age of 30, everyone should know what their mutation status is.
So that's one of the questions we got. Does the wisdom study include genetic testing?
It does, yes.
For what size panel?
We actually are focusing on the 9 genes that are associated with breast cancer risk. We actually partnered with a company called Color. They actually they have a 30 gene panel, but many of those genes are about colon cancer and so on. They're really only 9 or 10 genes that really are associated with any significant risk for breast cancer right now.
And I saw this asked and answered in the chat box, but I'll just confirm with you. Can men participate in the wisdom study?
Not men. Men can participate in I-SPY, but if they get breast cancer, but the reason is that the risk of getting breast cancer for men is so rare that it doesn't warrant screening.
So what is for men who are high risk? What is the recommendation for men for screening?
So if you're a BRCA carrier, for example, I mean, I think it's really probably getting a mammogram once a year, and probably for men getting an exam is probably one of the most important things. So at least doing that probably on a 6-month basis.
And I'm going to take 2 more questions and then we have run out of time. Regarding I-SPY COVID, is it open to those with people with breast cancer?
Can I ask a question?
Oh, you know what? We'll take all of our questions through the chat box, and any questions we don't get to tonight, we'll ask Dr. Esserman to follow up with us after the program.
And I'm willing to, we've got about 8 minutes left. I'm willing to stay a couple extra minutes if I'll give you short answers. Let's try and get through as many as we can.
Thank you, Dr. Esserman. Okay, the I-SPY COVID study. Is it open to those with breast cancer or breast cancer survivors?
The COVID trial is really for people who are critically ill in the ICU.
Okay.
So it doesn't matter if you have breast cancer or not. If you had breast cancer and you're critically ill and you're at a site that's participating, it would be open to you, yes.
Okay. And then one of the things that we actually hear a lot at Sheridan, this was asked in the chat box, is around communicating clinical trials to patients so that we can increase education advocacy so it's not so scary. What have you found most helpful to be able to communicate that?
Every single treatment that we have came from a clinical trial. No one if you had a HER2 positive breast cancer, everyone would want to get Herceptin. If it weren't for all the people who participated in that study, there would be no Herceptin. every new trial has to be introduced in a way that it has to be tested, because a lot of the things we think will work actually turn out not to work. And many of the things do, and that's how we make advances. And we're trying to do it in as efficient a way as possible. But participating in studies usually means you get the standard of care plus something else. It's not that people are not given appropriate treatment. Usually get very high quality care and treatment in trials. And just like in the wisdom study, none of the treatment recommendations are outside of the guidelines. It's just the guidelines are very varied, right? So we're trying to sort that out. And with that, I mean, it might be that what we find is that from this trial, we can even move farther and do further refinements. But for now, it's all within one guideline or another.
And going back to screenings, for people who are long-term survivors, someone who had a bilateral mastectomy and chemotherapy, what is your typical recommendation for screening for long-term survivors?
So I think it depends. If you had a bilateral mastectomy and you had a triple negative breast cancer, your risk period is usually 5 years. So you probably don't need any screening after about 5 years. If you're hormone receptor positive, the problem with those, your risk up front isn't as high, but the risk persists, and it can persist for 20 years. So just being aware of your body and thinking about it, again, you don't necessarily have to screen more than every year. And if you had a very low risk cancer, and again, people got treated a lot 10 years ago or 20 years ago that wouldn't get that same kind of treatment today. So kind of reassessing where you are and how much risk you have. And you have to put it in perspective with what your other health conditions are. But you don't want to overscreen there either.
Right, right. And we got a follow-up question about breast MRIs. What % do you deem as high enough risk to need a breast MRI once a year? This person has a 25% risk, tested negative for gene mutations, but has a strong family history of breast cancer.
So I think all that depends on, that depends a little bit on your breast density. And that's one of the reasons why we're doing the wisdom study. So we're kind of don't do MRIs except for the people whose 5-year risk is 5 or 6%. We think that, you really need to be in that risk of, 30% lifetime risk or higher. And I think it really depends. If your risk came because in your family there's a known mutation and you don't have it, you don't have that risk. That's really important to know. If in your family there's a lot of breast cancer and no one's got a mutation, then you can't explain your risk by mutation, and you then have to presume that you've got that higher risk too. It's another reason why we're trying to do the wisdom study, is that we're actually really trying to figure out better ways to assess risk, communicate it to patients, and find the appropriate pathway forward to give people the best care. And if you have high risk, by the way, the most important thing for you to do is go sit down with someone who knows a lot about breast cancer prevention and find out, especially if everyone had hormone receptor positive breast cancer in your family and you're young, take tamoxifen, take 5 milligrams, take 20 milligrams, whatever it is. Why not drop your risk in half, right? If you're older, there's 3 medicines that are approved, for breast cancer prevention. Do something, if you're overweight, try and lose weight, get exercise. Think about the things that you can do to really reduce your risk if you're at high risk. That's really just as important as screening, more important.
I think that's a wonderful way to end. I know we have more questions in the chat box. Dr. Esserman, you offered to stay a few extra minutes so we can go through them.
Well, before we do that, I want to tell everybody, don't forget to tell everyone you know about the Wisdom Study, wisdomstudy.org. Tell everyone you know. Again, if you all want, everyone should demand to have better, right? And the only way we get better is to try some new things. So I would really ask everybody to tell everyone they know about it. Okay, yes.
Thank you. And we put the link in the chat box.
Excuse me for one moment. I am only on the telephone, and if I don't get a chance because the chat box, takes first, is there any way to contact the wonderful lady here, to answer 1 or 2 questions outside of this meeting? Because I am just on the telephone. I didn't know
Send an email to Sharsheret, and she'll send it to us, and we'll get you an answer.
Yeah.
So what is this? Sharsheret at what? How is the email to Sharsheret?
If you registered for this program, we'll follow up with you after with our email so you can ask your question. We'll make sure to get it to Dr. Esserman.
Well, what do you mean email? You have my, because you have my email, so I have to email you. I'm a little bit confused. Can you just clarify?
Would you like us to give you a call back?
Wonderful, wonderful.
Wonderful. We can do that. We see your number on the screen.
We'll call, yeah, they'll call you and they'll get the question, then I'll answer it for you. Yes, okay, next question.
Okay, so I'm going to go back to our chat box. So I want to thank everyone for participating. We're going to get through a few more questions, but feel free to sign off at any time and take our survey as you head out the door. So are there any new developments, Dr. Esserman, for treating lymphedema, ketoprofen, anything on the horizon for ER/PR positives after the AI?
There are new things on the horizon for everything. And how are we going to find out if they work? We're going to do that through clinical trials. So I would say for lymphedema, there's a number. So if you have had more than 4 lymph nodes out, there are special exercise and weight training programs that you can get that reduce your chance of getting lymphedema by 75%. Probably the most important thing we can do to prevent lymphedema is to not take a lot of lymph nodes out from under the arm. And, you know, the best centers aren't doing that very much anymore. It's very rare that we really clear out the axilla, even if the nodes are positive, because it turns out that it doesn't really help. All it does is increase your risk of lymphedema. So getting to the right place for treatment matters. So having less surgery matters, and really ask about that. But also there are, you know, people are working on lymph node transfers, and there's a number of things that people are working on. There needs to be a lot more research, because there are a lot of people just doing stuff that doesn't necessarily help. But there are now super microsurgery to reconnect some of the lymphatics that can help. And in terms of estrogen receptor positive, there's a new class of agents called selective estrogen receptor degraders, SERDs. We actually are starting a whole trial called our endocrine optimization program. It's part of I-SPY, to take people who have hormone receptor positive breast cancers whose molecular subtypes are lower risk, but they have this kind of long arc, they're clinically high risk. We want to start finding better, more tolerable treatments for women, because they have to take them for a long time, and trying to find the right combinations. So there are lots of exciting new agents that are out there. So we're very excited and hopeful that this is going to make a huge difference as well.
That's great. Okay, this person wanted to know about new treatments for invasive stage 2, initially misdiagnosed as DCIS, now on 7 years of, I'm going to say this wrong, aromatase inhibitors. I'm pronouncing it wrong.
Aromatase inhibitors. Probably.
Thank you. Sorry. Anything new coming along for that?
Yeah, so just the things that I just talked about. If you're hormone positive, I think there's a new class of agents that are coming on the market. I bet within 5 years they'll have replaced the aromatase inhibitors. There's another class of drugs, the CDK inhibitors, that are being tested. Probably, you know, everybody doesn't need it, just people who are at high risk. And, you know, again, the trick is trying to figure out who needs what, and can you do it early enough so that people don't have to take a lot of treatment that they don't need, that sometimes is hard on them.
Got it. And then this is another question about visiting doctors during COVID. If someone has already had a breast exam, a mammogram, and done a bone density test, is there really another reason to meet with an oncologist in person, or can it be done virtually?
It can be done virtually. That's actually one of the great things that's a silver lining about COVID. You know, if you don't need to come in for something and you're doing all right, just check in, and you can do it online. No one has to get in their car. You don't have to waste your time looking for parking or taking public transportation. So it's really, and it's great. You can have anybody you want on the phone with you too. That's also nice.
Great. I think you've answered all of our questions. Oh, here's one more. If surgery doesn't happen first, when is the Oncotype test done?
There are several tests that can be done on the tissue. It can be mammoprint, it can be Oncotype. There's like 3 or 4 different molecular tests. And these are all about trying to understand what your risk is and what we think the response is likely to be. And that can be done on the core biopsy. And sometimes, it's really, there's no reason it can't be done on the core biopsy. In fact, that's probably a better sample to have it done on. And there are reasons why you might want to start with even a short exposure to hormone therapy, is you want to see how does the tumor behave under the pressure of the endocrine agents. And you can look to see how fast the cells grow later, and that actually can provide a lot of important information about the biology of the tumor. The reason we give the chemotherapy up front, and we do this all in I-SPY, this is what we do standardly, and we happen to use the 70 gene test from MammoPrint, because it gives us information about the molecular subtype, whether they're basal or luminal or HER2 type. And we're finding that the new therapeutics that are being developed, we can predict which ones are going to work best. And then not only do we predict, but we can actually find out if that's true. Does the tumor go away? Just like I showed you in that case example, not everyone's tumors go away. So then if it's not working, then what you want to do is find something else while you still can make a difference. And so that's what's important. So you can do it on a biopsy now. There's no reason why you have to there is no reason to do surgery first. Sometimes we will do surgery first if we think the tumor, if we can't quite figure out how big it is or how risky it is, sometimes doing the surgery first makes sense. Or if we think it's really super low risk and really all you need is it removed, there's actually an ultra low risk threshold out there. It's also off the 70 gene test. And if it's that, maybe you really don't need much of anything else, just have it removed, and you don't need radiation. And, for women who are 60, 65 and older, if you have a hormone positive tumor, the addition of radiation doesn't really add that much. It can reduce your local recurrence by maybe 5%, but it's not going to make a difference in whether you live or die. So it's really important to know, some people say, well, I just don't want radiation. Well, you don't actually have to have it, but you have to be able to take hormone therapy. And so you can actually do that first to see if you tolerate it. And if you do, then those are good options for you. So there's lots of ways in which you can be creative about how you order your treatments, to learn, to help make better choices, to help reduce the toxicity of therapy, and to maximize the chance that you're getting the right thing. So that's the way we personalize treatment, based on science and based on the data we've learned from clinical trials, right? So, and every person who participates in a trial not only is often helping themselves, but they're also helping everyone who comes after them to make. And for screening, that's one of the reasons why we say participate in the screening trial. You spend 30 years of your life screening. Why not spend 5 years, work with us, help us find the answer, be part of that whole movement of saying, hey, I'm tired of, why am I doing the same thing I did 30 years ago? I want better. I want the iPhone 20 of screening, but we can't get there without everybody helping us. So that's the best way to explain why research matters, because you want something better for yourselves, and you want something better for your mothers, your daughters, your sisters, and your friends.
Yeah. And if someone is high risk, what type of doctor should be consulted? It's a really important question.
It is an important question. So the universities almost always have a high risk or, a breast cancer high risk clinic. It can be some OBGYNs are really interested in this. A lot of breast surgeons do this. Sometimes it's a medical oncologist. Sometimes it's a nurse practitioner. What you want is someone who really is steeped in this. Part of the Wisdom trial, we actually have a whole educational program, and we have tools to help people understand their risk and do counseling as part of that, because it's not, as I said, it's not just about screening, it's about prevention and integrating the two with risk assessment. And so then we also help make sure that people can not only get counseling, but then get to a facility where they can, get an intervention if that's the appropriate thing for them.
Fantastic. Dr. Esserman, thank you so much for this. This was really incredible. I'm sure everybody learned as much as I did. I'm so excited that we had you, and we really appreciate your education. We'll be sending out this webinar recording in the next week. So anyone who wanted to look back at the charts, information that she provided, you'll be able to do that, as well as to share this with friends. and convince all of them to join the wisdom study in clinical trials. We appreciate you.
Okay, very good. Thanks for having me. It was really a pleasure.
Thank you so much, Dr. Esserman. Take care.